Thank you very much for that sexy introduction. Around the world, people love. They sing for love, they dance for love, they write, they make poems, there are legions, there are monuments built on love, they kill for love, In fact, we all are victims of love. We are all born out of love and sex, but we don't talk about it. 82% of men who are diabetics struggle with erectile dysfunction and don't talk about it. 40% of men above the age of 40 are having this issue, whether they have diabetes or no. There have been increased incidences of divorce because of impotence related to diabetes. In the courts of Kerala, there are 12,000 cases pending. In Japan, which is the most developed country, 50% of adults, married adults, are staying sexless. The problem is huge. In fact, it's a bigger pandemic than the COVID, which we had seen. In this next 30 minutes, I'm very delighted to be here amidst you all, august audience, to share with you and give you some nuggets of wisdom as how you as physicians can play a big role in managing these issues by just asking your patients about it. With pranams to God and thanks to my teachers, Dr. O.P. Kapoor, Dr. Prakash Kothari and Dr. Sashank Joshi, I always beseech them to bless me always. When you think of diabetes and sexuality, there are two things which we should know. The erectile dysfunction occurs as one of the first problems. And secondly, there is reduction in testosterone or hypogonadism. So, every physician or particularly diabetologist who are taking care of hyperglycemia and other things should definitely ask about this problem to their patients. Now in India, sexual health emerges as a new parameter for strong relationships. Gone are those days when patients were, women were not empowered. Today they are empowered, so they are asking for it. It's a huge problem. And there's got various etiology, vasculogenic, neurogenic, hormonogenic, psychogenic, etc., even genetic. But what I want to tell you is that in the penis, if the nerves stimulate, vessels circulate, muscles facilitate, and hormones regulate, everything can be fine. Why we should be worried about erectile dysfunction in diabetics? Because men with erectile dysfunction face higher risks of death. And there is definite evidence to say that ED precedes coronary artery disease, definitely. European male aging study with 1913 participants at various centers proved this. 80% of men struggle with ED in silence. When I Googled, I found Viagra had 196 million web pages and aspirin had only 53 million web pages. And this problem occurs as we age. We all are aging, aren't we? And we have longevity at us. So how do we want to live the 60 plus gifted years? In autonomy, dignity, grace, and be sexually happy? Or we want to be diseased, depressed, dependent, unhappy, sexually starved, or emotionally crippled? The choice is with us. There are 5 cities across the globe where people are living more than 130 years and are sexually active. Can we make India a blue zone? This is what it is. When we think of aging, what science tells us, that the antioxidative system, angiotensin 2, tumor markers like TNF-alpha, mechanical pressure, and endothelial nitric oxide synthetase all ultimately lead to production of reactive oxygen species, which leads to inactivation of the chemical signaling molecule nitric oxide, leading to endothelial dysfunctions and all the other complications. Now we are all aging, aren't we? So is life itself a disease? If aging is a disease, life is a disease? No, it's not. At this age, we all are in a state of pro-inflammatory status. And if you have immunosenescence, all these things increase. And we have a beautiful mechanism which is in place in our own self. If you restrict calories, it improves everything in your functions with the help of sirtuins. Sirtuins are the service to healthy longevity. And when we age, we also find there is altered mitochondrial dysfunctions, defective mitophagy, and mitochondrial damage due to reactive oxygen species, etc. And this all leads to mitochondrial dysfunction and leads to many complications. And that's what we say. See, mitochondria are the energy powerhouse of it. Every diabetic says, I'm feeling weak. And the reason is the mitochondrial dysfunctions. So when we have all these issues, due stress, oxidative inflammation, cytokines, DNA damage, ultimately lead to inflammaging. And diabetes is an inflammaging disease. Let me give you a new perspective. When we look at the intrapenile architecture, endothelial nitric oxide synthetase, which is present in the endothelium, a normal endothelium, produces nitric oxide with the help of an L-arginine. This nitric oxide is the chemical currency of the cell, enters into the corpora cavernosa smooth muscle cell, converts guanosine triphosphate into cyclic guanosine monophosphate with the help of an enzyme called guanylyl cyclase. This cyclic GMP, through various mechanisms, relaxes the smooth muscles of the corpora cavernosa and the blood enters into the penis. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5, PD5. So when you look at this, today what we have in our armamentarium is only PD5 inhibitors. Okay. And when we look at diabetes or hyperglycemia, advanced glycated end products, etc., ultimately lead to endothelial dysfunction and erectile dysfunctions. So there is definitely a link between erectile and endothelial dysfunction in diabetics. What else we see is there is structural and functional damage of the corpora cavernosa because of the less release of nitric oxide. Let me give you a little fresh perspective, which is very, very recently understood. Even Dr. Neha Agarwal beautifully elucidated that. Polymorphism, overloading of free fatty acid, hyperglycemia, increase the reactive oxygen species, lead to several mutation and mitochondrial biogenesis, including aging, results in mitochondrial dysfunctions, reduction in beta oxidation, increase in ROS, and decrease in ATP, ultimately leading to diabetes. So in diabetes patients, we see endothelial dysfunction as well as mitochondrial dysfunctions. If you look at the metabolic health, the respiratory capacity is decreased in patients who are obese, aging, and having sedentary lifestyle. But this can increase if you have a healthy diet, exercise, and there are certain good pharmacological agents which are seen. So in diabetes with insulin resistance, exercise has a lot of positive effects which improve your health and longevity. So diabetes-induced erectile dysfunction is endothelial dysfunction and mitochondrial dysfunction and leads to emotional dysfunctions. Now, what do we do for that? We have a beautiful drug called imeglimin. It is also known to improve the endothelial dysfunction and also improves the mitochondrial dysfunctions. Hemoglobin restores the mitochondria and improves erectile dysfunctions. So we have pharmacological agents which in patients who are diabetics, we can treat them. So you are only as old as your endothelium. Please remember that. If your endothelium is intact, everything is fine. So how do we manage erectile dysfunctions today? The first line of treatment is, of course, oral drugs. Second line is we give urethral prostaglandins, penile injections of papaverine, and vacuum therapy. If all these fail, we send our patients to androsurgeons who put implants, etc. We have 4 PD5 inhibitors, sildenafil, vardenafil, tadalafil, sildenafil, all have side effects and contraindications like nitrates. We can't give it to those patients who are on nitrates or having hyper. But in diabetics, what studies say, that if you give low dose of tadalafil, say 5 mg or 2.5 mg or 10 mg for 12 weeks, irrespective of whatever be the HbA1c, hypertension, prostatic hypertrophy or even dyslipidemia, they showed improvement in erectile dysfunction or sexual functions. So chronic therapy with PD5 inhibitors is now a valid choice because tadalafil is known to prevent the corporal fibrosis and veno-occlusive dysfunction that occurs when the patients are operated or have diabetes. So there are patients who do not respond to it. About 50% give up. The drop rate is about 4% per month. That's because there is not adequate sexual stimulation. They have not taken an adequate dose. They have not given enough time for stimulation. They take it after heavy meals or alcohol, and if the partner is not interested in having sex, and sometimes they get counterfeit drugs which are not. Also, we need to remember that all diabetic men have a lesser volume of testes. They have testosterone deficient or they are hypogonad. Oral testosterone reverses erectile dysfunction associated with diabetes, even those patients who fail with sildenafil. So giving testosterone is definitely a good choice. Enough studies to prove that combining testosterone with PD5 inhibitors in erectile dysfunction has been the basic rationale and clinical evidence. My friend Parish Dandona gave these patients 23 weeks of testosterone replacement in diabetic patients and found improvement in the androgen, estrogen, aromatase receptors, etc. So what do we have new in treatment of erectile dysfunction? Do we have something new available today? Yes, we have. We have a new drug called avanafil, available in the dose of 100 to 200 milligram. What is so peculiar about this PD5 inhibitors? The action is within 15 minutes, which is very good. There are less side effects of headache, visual side effects, myalgia, etc. And the half-life is only 5 hours. So this is the only PD5 inhibitor which you can give to your patients who are on nitrates. Ask them to skip the nitrates on the day when they are taking avanafil, when they want to have sex. They have sex, take avanafil, and then this drug washes out from the body within 5 hours. Next day again they can take PD5 inhibitor. Again they can take nitrates. Films, mouth dissolving films available in 50 milligram sildenafil, 20 milligram tadalafil. We have sprays, sildenafil, citrate, oral sprays available. So what's new in the medical treatment? We have SLX2101, mirodanafil, lodan. They're not available here, but they are available abroad. We have newer technologies called nanotechnologies, where smaller amount of drugs are injected in the particular tissues. They have less side effects. The effects are much more, which is seen. There have been a novel approach by light controllable nitric oxide donors and nanoformulations showing fantastic improvement. A beautiful study done in Switzerland by Belinda Smith. What she did was, she injected rats with DNA which caused erection in the rats when they were exposed to blue lights. Just in 37 seconds, these rats got erections by just exposing them to blue lights. So I suggest keep blue lights in your clinics if your patients are coming. They'll be very helpful. We have newer molecular targets like platelets, microparticles, myeloperoxidase, heme oxygenase 1, sonic hedgehog, galanin, slow kinase, plate PRPs, melanocortin receptor agonist, stem cell, gene cell, and we also have extracorporeal low intensity shockwave therapy, PRPs, stem cells, gene therapy, and nanotechnology. These are the newer perspectives of non-surgical treatments for erectile dysfunction. Of course, low-intensity shockwave therapy has been practiced very well. We have photoacoustic image-guided corpus cavernosum intratunical injection of adipose stem cell-derived exosomes. We are doing a good study on this. These patients have shown beautiful results. We have definitely new nutraceuticals like ginseng, ginkgo biloba. All these are old, but we have newer ones which are L-arginine and fenugreek. L-arginine is a nitric oxide donor, and fenugreek has got a chemical composition exactly like testosterone. When you give fenugreek, these patients improve in their free testosterone, which increases the desire, which is the foundation of everything. And if you combine with L-arginine, which is producing nitric oxide, so you're taking care of the desire and the arousal or the erections of these patients. So the mechanism of increasing free testosterone, because fenugreek saponate form have structures similar to testosterone, hence are able to bind to sex hormone globulin bound testosterone, and this dissociate testosterone from the globulin band and increase in the free testosterone. My friend Dr. Jyoti Dev put all diabetics on insulin pump and found 84% improvement in their sexual functions. Bariatric surgery improves cavernosal neuronal vasorelaxation and contraction mechanism as a result of amelioration glucose homeostasis in these. What's new in erectile dysfunctions? Do we have something very, very new and very simple to give to our patients? Yes, we have a lot of topical applications available today. We have L-arginine gel, 5% to 10%. We have transdermal gel of sildenafil citrate, an Indian study which is shown to be proving very effective. We have Med 2005, glyceryl trinitrate 1%. Just apply on the glans penis and you see the erections, which are very prostaglandins as topical therapies, which are available today. We give papaverine in the intracavernous tissue, but we have a fear of priapism. We have papaverine topical gel available today. We have Erector, which is a mechanical thing, but erections are maintained for a long time. We have Vibrect also. Surgical treatment with bionic penis called Tactra is available. So many new things are available. But all these things do not meet what the patients need. There is no cure, and sometimes they are not effective. So what do we do for it? Do we have something to give it to them? Yes, we have stem cell therapy, which is very effective. PRP is also effective, but not that much. But yes, in a beautiful study done by my friend in Houston, 7 diabetic men who failed medical therapy and didn't want to go for surgical treatment, they were given 15 million human umbilical cord blood cells infused into the corpora cavernosa. 6 out of 7 regained morning erections within 3 months, and these patients for the next 2 years did not need PD5 inhibitors. Metformin is known to improve the endothelial dysfunctions. SGLT2 inhibitors, a beautiful study which we did and published. SGLT2 inhibitors cause loss of weight, control hyperglycemia, improve endothelial dysfunctions, antioxidant effect. So all the vasculogenic causes of erectile dysfunctions are taken care of by them. So if you combine metformin with SGLT2 inhibitors, all the vasculogenic causes of erectile dysfunctions are taken care of. These patients start getting morning erections. They don't need an additional pill of PD5 inhibitors. So pill burden is reduced. Now let me give you my last part of my talk, my newer perspective. See, we know that the risk factor of all the risk factors is endothelial dysfunctions. So we need to target the endothelium perfectly. Do we have something to restore or reverse the endothelial dysfunction? Yes, we have statins, we have ACE inhibitors, antioxidants, L-arginine, estrogen therapy. My teacher, late Dr. R.D. Lele, published so many successful strategies to reverse the endothelial dysfunction, which is true. So he says that ACE inhibitors, statins, insulin sensitizers, all these things are pharmacological interventions to restore endothelial dysfunction and protect against so many diseases, including diabetes, insulin resistance, tumor growth, venous, etc. Latest what we read, there is a role of microRNA in erectile dysfunctions. Now microRNAs, single one, initiate many other RNAs to produce. So what is microRNA? There are more than 20 to 30 microRNAs, but microRNA 92A improved erectile dysfunction in the rats which were induced with diabetics and by suppressing oxidative stress and endothelial dysfunction. So several microRNA have been identified in patients with erectile dysfunctions. These expression is elevated in diabetic rats in the endothelial cells. This overexpression impairs the endothelial function and suppresses HO1 expression. Inhibition of microRNA 92A attenuates oxidative stress and improves endothelial function through enhancing HO1 expression and activity in these mouse, and this has shown to improve erectile dysfunction on a long-term basis. So 17 years of clinical experience with PD5 inhibitors have told us that these are not the drug of choice. They are effective, but they are not the only things which we can give. We need to advise our patients as first-line therapy, which is lifestyle changes coupled with counseling. What is lifestyle? You may be Hindu, Muslim, Sikh, but make lifestyle as your first religion. First religion. Enough stress have been given today also by several speakers about lifestyle, which is very, very important. Dean Ornish proved that patients with over 95% or 96% blockages in the coronary artery with intensive lifestyle changes improved in their coronary blood flow completely. And the lifestyle change, 10% fat, whole foods, vegetarian diet, aerobic exercise, stress management, smoking cessations, and psychological support. Whatever we are today is all because of genes, but 20% of how long the average person lives is dictated by our genes, and 80% is dictated by our lifestyle. So we need to improve our lifestyle, because if you improve your lifestyle, it has been studied that healthy lifestyle will reduce your pro-inflammatory status which you are in, improve your insulin resistance, oxidative stress and endothelial dysfunction, and you will have improved well-being and reduced burden of sexual dysfunction. See, when you look at the causes, most of the causes are modifiable risk factors which are there. And if you improve these modifiable risk factors, you will have a very, very good quality of sex life. Cleveland Clinic published their data saying that nutritional intervention in their original research not only halted but even reversed the coronary artery disease. See, look at this huge plaque which is completely open only with nutritional interventions. So what else you want? And 2 times Nobel Prize winner, or the doctor of the future, will no longer treat human frame with drugs but rather cure and prevent disease. So my take home message is, first line of treatment today we have is oral drugs, but counseling and lifestyle measures have to be followed. Second line I've already discussed, but in all these counseling and lifestyle measures have been the backbone of this treatment of erectile dysfunctions. So you need to think, if you consider erectile dysfunction as a disease or a symptom. If you consider it to be a symptom, give them pharmacotherapy, give them PD5, Viagra, etc. But if you consider it to be a disease, it needs to be reversed, it needs to be brought to cure. Regenerative therapy and phytonutraceuticals are the answer. So what should be the ideal prescription of a diabetic with erectile dysfunction be? First is counseling, lifestyle measures to be adopted as soon as possible. OHS and insulin, whatever you want to give, but prefer metformin and SGLT2 inhibitors. Statins if he has got dyslipidemia. If you are giving antihypertensive because of hypertension, prefer ARBs. If you want to give beta blockers, give nebivolol. If you want to give diuretics, give them indapamide. Low dose PD5 inhibitors if there are no contraindications. Low dose testosterone if there are no contraindications of raised PSA, etc. But monitor with PSA. L-arginine supplement with fenugreek, zinc, etc. is a must. Nutritional intervention, counseling and mental health checkup. So what diabetologists should know? Ask your patients for erectile dysfunction. Check their feet, retina and oral hygiene. Do a CBC and do a mental calculation of platelet lymphocyte ratio. There's an advanced glycated end product reader which you can clearly tell you what patient has got mild, moderate or severe erectile. Prescribe the right hypertensive. Check for depression in diabetic women. Do nutritional intervention and counseling. The onus of sexual health of your patients lies with you. Patients will not talk about it. You have to ask them, do you have problems in making love? Tell them all diabetics have some issues in the bedroom, but these are all manageable. He may not tell you at that time, but he'll remember it. The doctor asked me. If he'll come next time and he'll definitely ask you. And counsel them on what is reality. Tell them at 70 or 80 you may not be as good as you were 30 or 40. Counsel them on what our reality is. And tell them to increase the connect between each other. The joy of hugging, being embraced. And many patients who have erectile dysfunction, they take medications, they also have early ejaculations, they have sex, they ejaculate, they turn themselves on other side. They have no concept of afterplay. Now what is afterplay? Once you are ejaculated, You need to hold your partner tight, hug her, thank her, compliment her, tell her she was beautiful, she was awesome. You have to do everything what you did during foreplay again. Because if you are looking at a girl who's good looking, did a lot of makeover, anybody would say, oh, she's gorgeous. But if you compliment your partner in the bedroom, you're giving her a signal that you like her the way she is, and that speaks miles. So don't use your partners like a sleeping pill. And there is some role of women also. They should regard him as a hero and never give him any pressures to perform. All these women were abandoned by their husbands. So I advise all my ladies gathered here or their partners, they should spend money on their husbands and go to the parlors and look beautiful, look as beautiful as possible. So all these women got makeovers and again they were liked and admired by their better halves. Today every person thinks every wife is a mistress for her husband, miss for 1 hour and stress for the rest 23 hours. This is not true. This is not true. Today we have absolute persistent disregard towards the woman's satisfactions. The foreplay is a bore play. Penetration is okay, little bit. Ejaculation is early. You turn yourself and sleep other side. That's wrong. It's you have not satisfied. She's not completely orgasmic. So mutual satisfaction is the benchmark which defines a conjugal life. Even Kama Sutra mentions samma bhog, means equal joy. What is the secret of sexual happiness or fitness? What we need to understand is, if you want to become sexually fit, you will try to learn yourself, love your body, avoid excess of salt, oil and sugars. Mediterranean diet is very good. Give a U-turn to your metabolic imbalance. Have a regular rhythm of sex life. Increase your romance, increase your touch with your partner. Not eat less, but eat less often. See, it has been enough proved that nutrition is the main thing. You become sick for two things. One, what you put in your body, and second, what you do with your body. So we know that there is a mechanism in place in our own body where we improve our nutrition and we can heal even the crippling coronary artery disease. Enough evidences have been shown. And 2 times Nobel Prize winner Dr. Linus Pauling declared nearly all diseases can be traced to a nutritional deficiency. When he was receiving the 2nd Nobel Prize, who gets 2 Nobel Prize? Brilliant. And he has given a message to the world. Why don't we follow that? Why don't we counsel our patients on nutrition? Spend 5 to 10 minutes on tell them what to eat, what not to eat, how much to eat and all that. So we have all 4 PD5 inhibitors. They do not increase the desire. 40% of these patients are not responders. So we put them on testosterone. But we can't give it to younger patients because they can develop azoospermia. We can't give it to older patients because they can develop heart issues or failure. So what we have, the Raja of all is L-arginine, fenugreek, lifestyle modification, and of course regenerative therapy. But all said and done, at every age, try and love each other unconditionally, your partners of life, and respect your partner's feeling. Feminism needs to be adored, admired, trusted, and respected. We are all born out of her. She's the best phenomenon in the world. We need to care and be concerned about her wishes, her choices, her likes, her dislikes. Friends, in the end, I would say erectile dysfunction is not an option in diabetics, not for anyone. It is how gracefully we handle the process and how lucky we are as the process handles us. So today we've got so many things to give to our patients for ED in diabetics that this is a symptom which can easily be managed. So today it's really nice to know that if you diagnose ED, you are saving them from crippling events like myocardial infarction or stroke with them. It's a blessing in disguise. And it's really proven that erectile dysfunction today is a correctile dysfunction. And for this, you need to be having unconditional love and connect with your partner. Being monogamous is like a garden. Being polygamous is like a jungle. Both are beautiful, but jungle is little wide. But if you are monogamous, if you think your life is like a garden, you need to devote time. You need to cut the right type of grass, you need to put water, so you need to devote time. So Voltaire beautifully said, try and cultivate your own garden, be monogamous. If you have issues, if you have patients who have got erectile dysfunction or any sexual issues, they will go to quacks. Don't send them to quacks. Treat them yourself, work them up properly, counsel them on nutrition and what to do. If you can't do that, send them to a good sexologist. he will see that he gets a good erections. This is my book, Sex Has No Expiry Date. My last slide. Diabetes is the sexual health tsunami of our century. Erectile dysfunction is prevalent and the earliest marker of coronary artery disease. Erectile dysfunction in diabetes is endothelial dysfunction and mitochondrial dysfunctions. PD5 inhibitors are effective. Novel treatments is low-dose PD5 inhibitors, statins, metformin, SGLT2 inhibitors, imiglimin, which improve endothelial and mitochondrial dysfunctions. Short course of testosterone can be used with caution. Lifestyle modification with L-arginine supplement and fenugreek are a boon. If you do so, diabetes remission is a fact and not a myth. I'm not talking about reversal, but remission is definitely possible. If you do so, erectile dysfunction is a correctile dysfunction, and don't let your diabetics die in bits. If all happens, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have.